So welcome everyone to my first ever progress report. I would like to introduce you to some of my research work that I have been doing since September in the field of dermatology, especially of the clinicopathological evaluation of cutaneous lupus. My name is Laura Bokor, and I'm a medical doctor and a full-time PhD student at the Department of Dermatology, Venerology, and Dermato-Oncology at Semmelweis University. Let me also share my vision with you, which is to improve the quality of life of patients suffering from cutaneous lupus erythematosus. In order to achieve my vision, my mission is to find more efficient therapeutic options for this disease. Currently, I have two ongoing projects, both in the topic of cutaneous lupus, but I'm going to use different methodologies. So let me talk about the first one, which is the investigation of the efficacy and safety of novel therapeutical options in cutaneous lupus, and I'm doing a systematic review and meta-analysis to answer this question. So first, I would like to share some pieces of information with you on this disease of cutaneous lupus. Cutaneous lupus erythematosus is an autoimmune skin disease. There are more than 300,000 new patients every year worldwide who suffer from inflamed, scaling, or scarring lesions, or they might have scarring alopecia. Due to these symptoms, these patients have a substantial decrease in their quality of life. The gold standard therapies for cutaneous lupus are topical or systemic glucocorticoids or antimalarials, but as you may already know, glucocorticoids might have severe side effects, and the response rate to antimalarial treatment is only approximately 50%. But recently, novel therapies have emerged, for example, biologics like anifrolumab, or small molecules like JAK inhibitors, but there's only limited evidence available on the use of these agents in cutaneous lupus. So therefore, our aim is to find the most effective and safest novel therapy for cutaneous lupus erythematosus. According to our aim, our clinical question is quite similar, which is what is the safest and most effective novel treatment in cutaneous lupus? We are using the PICO framework in our project, where our population is patients with cutaneous lupus. Our interventions are biologics and small molecules. Our comparator is either placebo or no comparator at all, and our outcomes are efficacy and adverse events. We are measuring efficacy with the CLASI score, which is a specific score for cutaneous lupus, which evaluates the activity and the damage of the disease on the scale from 0 to 70. We hypothesize that anifrolumab is the most effective and safest novel therapy in the treatment of cutaneous lupus. And the clinical implication of our study would be to help clinicians choose the most effective and safest therapy options for their patients in order to improve the quality of their lives. We conducted a systematic search in the three main databases, and here down below you can see my search key, which consisted of two domains. The first one is the disease, and the second one are the novel therapies. Here you can see the flowchart of my selection. My search resulted in over 18,000 hits. After duplicate removal, it was a little bit over than 12,000, so I'm working on the title and abstract selection currently. In the next few slides, I would like to highlight some of my key articles. Here in this first table, you can see 3 randomized controlled trials on anifrolumab. They all evaluated patients with systemic lupus erythematosus and skin symptoms as well. And as you can see, they all used the specific form of CLASI score, the CLASI 50, as one of their outcomes. In this second table, you can see 3 RCTs on baricitinib, which is a novel JAK inhibitor, and as you can see, they also used the CLASI score as one of their outcomes. And this is the same case with my third table and these 3 RCTs with litifilimab, which is a novel biologic agent. And jumping on to my second project, which is the epidemiological evaluation of patients with cutaneous lupus, and I'm going to do a retrospective cohort study in this project. The incidence of cutaneous lupus is 4 over 100,000 people. However, there's still few available data on the epidemiology of the different subtypes and subgroups of cutaneous lupus. So there are still several open questions about this matter. For example, on the difference of gender distribution in the different subtypes, the prevalence of autoimmune or malignant comorbidities, the clinical or laboratory differences in these subgroups, the prevalence of systematization or the epidemiology of rare subtypes. Unfortunately, there's only one previous register available, which was published in 2013. It collected data from that 4 years and evaluated and analyzed the data of over 1,000 patients. So therefore, our aim is to collect data from at least 10 years at the Department of Dermatology, Semmelweis University, which is one of the biggest centers in Hungary for autoimmune skin diseases. Our aim is to analyze the data and analyze the prevalence of rare subtypes, the male-female ratio in different subtypes, the prevalence of comorbidities, smoking, systematization, the different circulating antibodies, the lupus band test positivity, or the first, second, and third line treatment options. So all in all, our aim is to have up-to-date epidemiological data on cutaneous lupus erythematosus. In summary, I have these two ongoing projects, both in the topic of cutaneous lupus, but the first one is focusing on the therapy, and the second one is focusing on the epidemiology of this disease. And thank you very much for your attention, and I would like to say goodbye with the words of Banksy: if you get tired, learn to rest and not to quit. Thank you.
Thank you, excellent presentation. I would like to ask, regarding your first topic, and every single RCT, we're comparing them to placebo. Is it ethical to leave this patient just on placebo? That's something unclear for me. And if yes or no, I would also be very interested, what is the difference between small molecules and biologicals and biological versus JAK inhibitors? Are there also this information in literature? Do you have any knowledge about this?
You mean the efficacy? So comparing the efficacy of these or the mechanism?
No, efficacy.
The efficacy.
What is better for patients?
Efficacy. So unfortunately, we don't have new information. Which one is the better? Both have meta-analysis on baricitinib, which is a JAK inhibitor, and on anifrolumab, which is a biologics. But it was inconclusive. Both, because they had RCTs that had reached the outcomes and they had that they did not. So there are still questions about the efficacy. That's why we are trying to do a network meta-analysis on these projects where they all compare to placebo, but there is also plenty of observational studies, case reports, and we would like to include that as well, but not in the network meta, but in another evaluation or form, a statistical form, to see the whole picture.
Congratulations, fantastic presentation. Yeah, my question would be on anifrolumab. So why is it highlighted? Why do you compare all the other treatments to this biologic drug?
Thank you for your question. So anifrolumab is monoclonal antibody that targets the type 1 interferon receptors, and type 1 interferons plays one of the major roles in the pathogenesis of cutaneous lupus, so that's why we hypothesized that this would have the best efficacy on the disease because of the pathomechanism and the mechanism of action of the drug.
And for the clinical trials, what was the efficacy results of this drug?
It was very good. But it was, so they had 3 RCTs on anifrolumab. It was very interesting because 2 had very good efficacy results, especially on skin symptoms and joint symptoms of systemic lupus. But the third one was inconclusive, and they did not reach those outcomes. So we will see.
Yeah. Interesting, thank you.
Congrats for the great presentation. I just had one question, whether through these RCTs, these novel therapies, were they effective also in treating or improving the condition in the patients who exhibit neuropsychiatric symptoms from neurolupus, or it was mostly the improvement in cutaneous?
So unfortunately, in these trials, they excluded all patients who had severe systemic lupus erythematosus, including neuropsychiatric symptoms. So that's why I cannot answer your questions, because they just don't include them in these trials, unfortunately, since of the severity of the disease.
Your second project is a retrospective cohort study. What is your strategy to handle the risk of bias when you get the data and the results? Thank you.
Thank you. It's a very good question, and we still have to think about it. We have already tried to have some form of strategy on it, but yes, it's very difficult, since collecting the data would be only my job and no one else's. So that's a bias in itself already. So we don't know it yet. We still have to form the strategy for that.
You mentioned that you would like to conduct a network meta-analysis regarding the different types of new novel therapies. Have you considered including then the standard care as well? I mean, the standard therapy as well? Because I have seen that your comparator is only placebo or no comparator at all. What is your approach on this?
Thank you for the question. It's very interesting, because we started with the exact same idea in September, but unfortunately they don't have not even one study where they compare novel treatment to antimalarials or antimalarials plus glucocorticoids. So that's why we just had to exclude that options, because we just cannot do any form of meta-analysis on that because of the lacking data.
Thank you very much.
Regarding the retrospective cohort project as well, how would you manage to fill out this missing data? That might be the case, also because you have many variables. So do you have any strategy for this yet?
So I'm in a very fortunate position, because I'm a PhD student at the clinic. So that's why I have already started that retrospective cohort analysis. That's why I can answer to your question. There's only few missing data, fortunately, which is why I'm in a very lucky position. And most things that are missing are probably some older patient photos regarding the symptoms, but not the laboratory data. They have quite a strict step-by-step process to evaluate these patients. So basically, I almost have every data in that database that I would like to analyze.
Thank you.
Thank you.